want to introduce again Dr. John Mahan, our co-founder, and I'm going to have him say a few words before we go to the questions. Thank you.
Great. Well, thank you, Maria. And we look forward to having a conversation with you all for the next almost 30 minutes or so. If this was real normal time, we would be live and enjoying each other's company in person. Unfortunately, we're not there. This is our 13th year. It's the first one that is virtual, and we feel the difference, I'm sure, as you do. We're hoping to be in person next year. We anticipate that we'll be able to get together sometime around February, Valentine's Day, perhaps. And we will commit to having a good time when we get together personally, as well as good education and good learning. So thanks for joining for this conversation. And I'm going to turn it over to our co-founder, Dr. Ferris, who is really the engine behind the RRI Pediatric Nephrology Fellows Conference. Maria?
Thank you, John. Honestly, I'm so excited to see you. It makes me nervous. This is, I look forward to this every single year, the crown of everything. There was a question in the chat room for Dr. Filler. Would you mind reading the question, Dr. Filler, for the audience?
Not at all. So the question was in regards to the second point where the parents chose different than what we recommended. The question was, would you consider bilateral nephrectomy, hemodialysis, and PD catheter insertion concomitantly, and temporary hemodialysis bridge to PD while waiting for PD catheter healing? That is exactly what we proposed to the parents, and they didn't want that. They were living quite far away from the center, and Dad, who is extremely knowledgeable in the field, felt that it would be worthwhile trying with a unilateral nephrectomy, and he wanted to spend as little time in the center. Basically, it would have meant that they would have moved to the center, and that's why we did what we did. But what the question is exactly the standard of care. We would actually even plan the transplant and do the bilateral nephrectomy dating back from the transplant date 6 weeks, and just do 6 weeks of hemodialysis. We would have actually saved them from having the PD catheter, but that was unacceptable to the parents.
Thank you so much. Can we stay with you, Dr. Filler? So the management of congenital nephrotic syndrome is very challenging. We have all this complication with infections, thrombosis, impaired growth, you name it. In the past, early nephrectomies were recommended. So before they get into trouble, do they still have a role? It sounds like from your presentation. Can you elaborate a bit?
So there's actually a really nice paper that came out in Nature Reviews Nephrology here this year. Olivia Boyer was the primary author, where they are actually addressing that exact question. So the management has to be focused on stabilizing the patient, minimizing the protein, the consequence of the protein losses, and very importantly, that the baby will have to thrive. If you do that with ACE inhibitors, you do that with albumin infusions, you could combine them with IVIG. But if all of that is failing to achieve freedom of infection and failing to achieve thriving, then there's still a role for bilateral nephrectomy and doing what our Finnish colleagues have taught us for decades, which is to remove both kidneys for the congenital Finnish type, and then when they're about 1 year old, then pursue with the transplant, and in the meantime focus. Because sometimes the losses are so vast that it's impossible to achieve these therapeutic goals. But,
so Guido, it reminds me with CKD, we talk about the fifth vital sign, which is growth.
Yes.
So if your kid with congenital nephrotic syndrome is growing with all your machinations, then you're doing something right. But if the kid's not growing, that really is that sign that even if the GFR is not bad, the kid is not good. And we've certainly nephrectomized congenital and infantile nephrotic syndrome patients with embarrassingly good GFRs but terrible clinical problems.
Exactly.
And let me stay in that vein for one more question, Dr. Filler. What if the patient has a WT1 dominant gene? And I know we have an audience that not everybody has access to genetic testing. I acknowledge that. But what about those countries that do? What is the role of the WT1 gene dominant?
So these patients have congenital nephrotic syndrome, just like Finnish type or like other private NPHS1 or NPHS2 mutations that are severe enough to cause the presentation early on. But with the WT1 dominant gene mutation, they are at grave risk of developing Wilms tumor, and therefore a bilateral nephrectomy has to occur before the transplant.
Thank you. There is a question from Hannah and it went away. Would you consider bilateral nephrectomy, HD and PD catheter insertion concomitantly and temporary HD to bridge the patient while waiting for the PD catheter to heal?
Yeah, so that was the proposed plan of action. And the father felt that medical nephrectomy was intermittent plus the unilateral nephrectomy would be the better choice. This was all, so the important teaching point for this case is that we have to make some shared decision-making, especially with very knowledgeable parents. And for them, avoidance of having to stay at the transplant center far away from the home was a very important value. And it was because of that that we agreed to this approach, which fortunately worked. I mean, in retrospect, Dad had been right about every single thing. But, you still have to propose the things as per what the standard of care is. And we would have done exactly that. Well, we would have actually even avoided the PD altogether and just done 6 weeks of chemo and then go ahead with the transplant because we had mom worked up for the transplant.
Well, we realized that these parents were extraordinarily trained and aware of what's going on. This same request could have come from any parent to delay the aggressiveness and to hold on and see what happens. But thank you for sharing. This was a very interesting patient. Let's move on. There's a question from the audience about recurrent urinary tract infections related to long-term vesicostomy. Dr. Melvin Bonilla, do you want to address that?
Yeah, I think that they were talking about our patient. In our patient, actually, the last issue that we had to confront is he's still surviving, he's still alive. And this is a patient, obviously, that have a lot of comorbidities. And the kid is on the ventilator. And at this point, we were deciding, if this patient will eventually get a kidney transplant and this patient had a better prognosis, probably you will go for vesicostomy, do more bladder studies to make sure that you have a bladder ready for a kidney transplant. But it seems like this is not the case of this patient that has so many comorbidities. So the idea here was, how can we improve the quality of life of this patient? And the major issue is that he has been in the hospital for a long time for urinary tract infections. So we did a vesicostomy, and the vesicostomy probably have two major indications here. Number one, actually, obviously, when you have a vesicostomy, your urine is going to be, you're going to have colonization of the bladder, and it's going to have bacteriuria all the time, but it doesn't mean you have an infection. Can you get an infection? Certainly, we can get an infection. But in this case, actually, the infections there were because the patient didn't have proper bladder emptying. So we're doing the vesicostomy to make sure that you have proper, adequate bladder emptying, and this will decrease the urinary tract infections. And in the case of our patient, actually, since that time, he haven't been in the hospital for UTIs. He was in the hospital once for seizures, but not for UTIs. So once we did the vesicostomy, UTIs has been away. The other major indication for the vesicostomy was the pressures. You have a small bladder, trabeculated bladder, and more pressure. If you have a high pressure system, that will eventually lead to more kidney failure, more parenchyma damage, and eventually kidney failure. So you want to also release that pressure, and that is the other indication for the vesicostomy. So this patient obviously have advanced CKD, but we want to basically preserve kidney function, and this was the other indication. So certainly vesicostomy, you're going to have a bladder that is exposed. to bacteria, but usually what you get is asymptomatic bacteriuria, you get colonization, but you decrease significantly the incidence of febrile infections, which is basically what you don't want here.
And
Thank you.
Melvin, that's certainly been our experience. Typically, when a kid with a vesicostomy gets a symptomatic UTI, it means the vesicostomy is not working well. It's not draining. It's really an indication to go in and figure out where the obstruction to the vesicostomy is. You know, it also reminds me that for urinary tract bladder obstruction, you know, vesicostomies are great. It's just they're not great for life, right? When you're a baby in diapers, okay, but obviously, as our patients hopefully are able to enter the world, the vesicostomies become not an acceptable option. But for some of these special children, like your child, that kid could have a vesicostomy for life and really do well from a UTI standpoint, and that quality of life issue.
I would like to add another aspect that our urologists have always taught me, and that is that you continue to cycle the bladder when you have a vesicostomy as compared to any diversion, which is actually really helpful for if you want to plan a neobladder or bladder augmentation with metrophenol, etc., that the bladder continues to be cycled. When we have a prematurely born PUV baby, we do a vesicostomy and don't attempt the primary ablation of the valves, especially when the laser is too small, too big for a small baby. And in my experience, I think the urinary tract infections are a rarity. They're not very common at all. I would agree with John that they happen only if the vesicostomy isn't working well. And the urologist can really help by good vascularization of the bladder tissue so that it doesn't shrink.
Yeah, exactly.
Very well. Again, let's since you have the microphone, Dr. Bonilla-Felix, if the decision is to forgo dialysis, if the family says, nope, we're not going to do dialysis, how do you approach the family? How do you help the family, one, continue to stay on that decision, or maybe did they want to change their mind? Can you give us some ideas?
Yes, I think that if we go to our case, if the family will decide to forgo dialysis, that probably will be an easier decision, because this patient actually and I think what we need to keep in mind with this patient have, severe oligohydramnios, severe pulmonary hypoplasia. So the prognosis when you have this severe hypoplasia, pulmonary hypoplasia, is pretty bad. So if your family doesn't want dialysis and everybody in the team agrees with that, it's much easier. And basically you have to support the family. And I think one of the things that we have to realize as nephrologists is that our role as nephrologists is not only to dialyze, it's not only to do transplant. Our role as nephrologists is to stay with the family. And we have to be there. And even when we stop dialysis, our role as a nephrologist doesn't stop there. Actually, what I believe is that if you decide not to dialyze, not to do transplant, this is when you really need to be very close to this family, because the family is going to go through a really, really hard time. The issue could be when the family wants to do dialysis in a patient like this, and you have a patient that you really know that he's not a candidate for dialysis because he has so many comorbidities that he's on a mechanical ventilation, he has severe brain damage. So this is not the patient that you want to do kidney transplant. And then you start thinking, is dialysis really, because when you start thinking about dialysis, you're going to prolong the life and you're going to improve the quality of life in this patient. And again, quality of life, as we said, is very subjective. But in a patient like our patient, when you start thinking about prolonging the life and quality of life, if you're not going to get a dialysis or you're not going to get a kidney transplant, then basically it's a really tough decision. And if the family wants to do dialysis and you don't want to do, I think this is when you really need to sit down with them. My experience so far is that I don't remember a family that decide any different from what we really want, because if you establish a good relationship and you show this family that you really care for them and for the kid, usually they will accept whatever you said, as long as you're there, as long as they understand you're really doing the best for the patient. I can't really remember any family that says, that we say, this patient is not going to survive and they want to do dialysis and they keep insisting on that. And the other issue that we also mentioned is sometimes the family, you're not clear about what is the prognosis of this patient, and you might start doing dialysis. But once you start dialysis, it doesn't mean that you need to stick with dialysis forever. Sometimes the patient will decide itself because you're going to see the patient is deteriorating, and the family will start thinking, well, this is probably not a good idea. And you might get to the point when you talk to the family and you say, well, this is it. The quality of life this patient is not good, and we're not doing anything really because we're not going to be able to do a transplant eventually. And when they see what dialysis means in the patient that has so many comorbidities, sometimes the family are the one that they're going to they're going to understand. So sometimes you might need to do that for a while, but the family is going to realize this probably was not a good decision, and the family, and sometimes the patient decide by themselves, they're not going to be able to tolerate dialysis, okay?
Yeah.
I think that the worst thing is you shouldn't be confrontative with the family. You should not play like this is the team that don't want to do dialysis. And when you become like that, it's really a mess, and you never should do that, because the idea is you have to be compassionate. You have to be on the family side. So if you are on the family side and you show them you're on their side, it's much easier that they're going to believe and they're going to do whatever you say.
I quite agree. Any comments from John or Dr. Filler?
I'd like to add that it's very important that you actually set certain periods of time to reconsider a decision and to discuss it again. I remember vividly a case when I came to East Berlin after the wall came down, and a child was high output renal failure, was led to die. The parents had decided that they didn't want any renal replacement therapy, but there was no follow-up and there were no discussions planned to reassess. And the child presented actually at 1 year of life with a creatinine of about 12 milligram per deciliter, and had the most horrific bone disease that I've ever seen. In fact, we were trying to do a physical, and the bone would actually bend like it was a gummy bear. It was terrible. And we reassessed that, and then they're so happy that the child got a kidney transplant after we stabilized the kid. And so it's, I think, extremely important that no matter what the decisions are, that you signal to the parents that the decision can be revisited, and that you set a schedule to do the revision.
Yes, I agree, Guido. The idea is no decision is inviolate, right? You can always reassess. Conditions may change, their perspective may change, but I love the way you put that you set up time for revisiting those decisions. I think that's really valuable.
Thank you. I would like to add a comment that is important, and I'm not sure in other countries how much hospice services and palliative care are available. But I would like to propose that they are important parts of your team, and that if you can, consult those services early and often. The advantage of consulting them, they not only are used to speaking with the family about end of life, that team will be at the house, will be with the family, and most importantly, will stay with the family 6 months post-death. And they will provide services not just to the patient and the parents, but also to the siblings, the forgotten ones, the healthy siblings. Yeah. So I want to make a plea for everybody to think about it. If we don't have access to hospice or palliative care, please learn about this topic. Dr. Bonilla-Felix.
I just wanted to, what you mentioned is extremely important. We, as I said before, our role as a nephrologist cannot be defined just as a transplant physician or a dialysis physician. And if we make plans for transplant and we decide what do we need to do, and we have a specific plan for the transplant, and we have a specific plan to do dialysis, we have to do the same thing for palliative care. So we need to have a structured plan. So if the decision is to forgo dialysis, you sit with the family, you do your plan, and you dedicate the same time that you're going to do as if it was transplant or as it was dialysis. So you have to make sure, as you said, this is not just on dialysis and this is it, go home. You have to have a plan including palliative care. And you have to be available with to the family too.
Terrific. I'm gonna take questions from the chat room on biphosphonates. John,
Okay.
are there kid-friendly forms like chewable gummies? And the other question from Jose Garcia: what are the side effects that we should be watching when we use biphosphonates?
So let me touch on the kid-friendly forms. No, there are none. So unfortunately, bisphosphonates have not been well studied in children, and oral bisphosphonates have not had any good controlled or randomized trials in children, oral forms. We have used the oral form that is used in adults, the 70 milligram, for example, dose of alendronate, or the 5 or 10 milligram dose of alendronate in children. We've had the same experience that's been published by a few centers in small numbers, which is about half the patients seem to get an improvement in bone mass and about half do not. We don't know if the issue is compliance, if the issue is GI intolerance and therefore patients avoiding the medication. There are no good pharmacodynamic studies in children, so the dosing may be wrong. So by using an adult sort of sized, adjusted down to the child dose, we may be way off. So as a result, in our metabolic bone program, treating kids without kidney disease, we've treated over 500 kids with the intravenous forms of bisphosphonates, initially pamidronate, now strictly zolendronate, and they work very well. We've got good dosing parameters. We know what to look for. So our default is to do IV unless there's some reason the child cannot get an IV, and therefore we're going to try oral. We've had a couple families where they've refused IV, but they're willing to try oral. But I can tell you about half the time it doesn't work. And since we're treating kids with evidence of bone fragility as well as low bone mass, in other words, these kids have had fractures, treating something that is about a 50% success rate doesn't feel right for us healthcare providers as well. So unfortunately, no good oral forms. There's no liquid form. There was at one point. It was not studied in children and it went off the market. So we struggle with bisphosphonates in children and really have to rely on the IV form. The IV form does have some important considerations. There is the first pass cytokine release phenomena that occurs in approximately half of the children. So we need to be aware that some of the kids will get myalgias, headache, GI distress, fever. It's like having the flu. We give the kids Tylenol or ibuprofen to minimize those side effects. But we also recognize that when they get their second IV dose a few months later, they almost never have that. So it's really related to the effect on the osteoclast, the release of the cytokines into the circulation. And when you come back a couple months later, there's not many osteoclasts left. So you're not going to get the same cytokine release phenomena. The other big thing, and I have to just reinforce, is hypocalcemia. These drugs, if they work, prevent the osteoclasts from mobilizing calcium from bone. So we always make sure the kids have adequate 25D levels above 30. And if it means we have to start them on vitamin D before we give them the bisphosphonate, we do that. And then lately, we've been giving the kids oral calcium for 2 weeks prior to their first dose of IV bisphosphonate, just to minimize that calcium drop.
Okay. Thank you so much. Obviously, the time that we have left for questions is not enough. We have a number of questions that I'd like to send you privately, John, and then we'll just try to figure out in the chat room.
Yes.
I want to take the last a few minutes for important announcements. Mm-hmm. First of all, I want to congratulate, let me see, we have 41 people in the audience, and I would like to congratulate C. Farkas Stylis, who will receive the John Mann Award for the abstract Understanding Delays in Pediatric Kidney Transplant Waitlist Activation in Complex Cases. Congratulations. And the Joseph Flynn Award is going to go to Guatemala. It's going to go to Dr. A.L. Galvez for the work on implementation of an exercise program in combination with nutritional support in the pediatric hemodialysis unit in Guatemala. All of us congratulate you. wonderful work. And unfortunately, I don't have time to tell you what an honor is receiving an award from wonderful doctors like Joan Mann and Joseph Flynn. We love them. Because I have one more piece of good news for everyone. So you heard Dr. Filler making a comment about his book, The Successful Academic Scholar. And I would like to thank ProKidney, because they will buy all the fellows a book that will be sent to you. Unfortunately, it will be a, Dr. Filler is going like this. It's a surprise for him too. We were going to try to do the surprise for you as physical books. So Dr. Filler would write an autograph, a dedication. Because of this setting, we cannot do so. But congratulations to all of you fellows. We really think the faculty hope that you will enjoy this award. And I want to thank Crystal Johnson for this terrific work that she's put together with this conference. So let us congratulate her.
So Guido, maybe you can type out a congratulations message, sign it, and Maria can email it to all the fellows so they can cut it out and paste it in their books.
Happy to do that.
That's as close as we can get to an autographed copy.
Yeah. Oh, one last thing. I sent everyone an email about joining us at 4 p.m. for virtual happy hour with the beverage of your choice. We'll get together. And Crystal, do you have anything else to say? No. All right, guys. Well, let's go to the next topic. And I have to wrap it up, I was told. So I'm sending kisses and hugs to everybody. We'll see you in a minute.
Thank you.
Okay.
See you.
Bye-bye.
Thank you, wonderful speakers.
Bye.
Thank you.